Hi, I'm Jeremy. Maybe you've seen my subreddit, which is r/cervical_instability, or maybe you've seen me on some of the Facebook groups, and you've seen that I'm a fellow lucky CCI patient, but I'm doing pretty good now. I've had 2 PRP sessions and 2 PICLs with Dr. Centeno, in addition to curve correction and physical therapy and strength training, and just kind of getting back to life as of recently. So standing now. Just got in from the gym and fairly active, still working on it, but overall pretty good. But I try to post a lot about that journey on here and on the groups and such, and just kind of throw stuff out there that I learned from the doctors, or have the doctors talk directly to the audience about what they do and what they offer. So, and there's been a lot of questions about a doctor named Dr. Agnes Stogicza, who runs a clinic called PSI Pain Clinic or Fagydalom Clinica in Budapest, Hungary. And everybody's kind of wondering the same thing. Like, who is she? What's her training? What does she offer? Does she do the anterior injections to hit the alar and transverse ligament? If so, how? How much experience does she have in that? And most importantly, are patients kept safe, and how? And also the efficacy, and just many questions. People are all wondering. So I figured, why don't I track her down and do just a discussion and have her talk about all these things, because I'm not a doctor. I don't think any of us in here are. So it's probably best for the professionals to talk about that stuff. But she was nice enough to sit down for about an hour late at night for her, because she's in Hungary and I'm in the US. But she answered a lot of those, and I figured, why don't we post this and just kind of open up a discussion. So if you want to chat with her, you go to fagydalomclinica.hu, and you could do telehealth here. I think she'll review your scans, kind of talk about your case and such. And I'll say this. So I've already mentioned I'm not a medical professional. None of this is medical advice or an endorsement or anything. There's no like business or influencer thing behind this whole thing. Really, it's been mostly me posting about my journey along the way. But when you're deciding on what treatment to do when you go into this regenerative route, you should know that most of this is considered experimental, whether that's in the US or Europe or South America or whatever. It's still in that experimental phase. So you're going to want to get second and third opinions, stay in close contact with your primary care physician or whoever your treating doctor is for this, and read the research yourself, and ask hard questions to these doctors, and also look at what you have the means to do in your specific case and all that. So but I thought for that research part, for the informational part, maybe I could help by having Dr. Stogicza come on here and chat. So that's what we did, and enjoyed the interview.
Why don't we start off with a little bit about your background and experience? So could you just kind
Yeah,
of introduce us to you and your experience?
of course. So I trained in Budapest. I'm Hungarian by birth. And I did pain management here since actually 2002 is when I started pain management. And in 2010, I went to the States and I did a fellowship at University of Washington. And then I stayed on as faculty. And I would say, for the interest of this group, my interest with headaches started there, just because the Center for Pain Relief at University of Washington had a very strong cooperation with the headache clinic. So everybody who had a trauma history and had cervicogenic headache and tension type headaches and other funny headaches that the neurologist couldn't deal with came to our clinic, came to me. And I started regenerative medicine back in 2006. I actually learned it in the States, and I was the first one to bring it home to Hungary, to here. And so I've been doing regenerative medicine, and at University of Washington, I combined regenerative medicine with the headache knowledge. So from 2010 to 2017, I was at UW, and just as faculty, and I was training fellows and residents. And I actually been doing these cranial cervical junction injections since then. First, I was doing prolotherapy, and then I was doing PRP and stem cells, and now I do fat-derived stem cells here in Hungary. I also practiced in Canada, and I did another fellowship at UBC. And at different countries, I had access to different approaches. I had Prolo at UW, then I had PRP in Canada and Prolo in Canada, with sedation in UW, without sedation in Canada. And here in Hungary, I'm my own boss. So I have exactly what I like. I use the product I like. I do the anesthetic I like. It's pretty good. It's in my own lovely clinic with a nice group of people. And I still teach this procedure. And just to answer one of your questions, all those fellows I taught at UW for the posterior approach for the AO joint, they are all doing it around the States. So I can even find you some who do the posterior approach. The anterior approach through the mouth, I started later. And I have not trained anybody to do that other than the fellows here in Hungary.
Cool. And you've also done some anesthesia. Are you an anesthesiologist or something?
Yes, very good. By training, I'm an anesthesiologist and critical care physician. Yes.
Okay, cool. Great. And how long has the clinic in Hungary been open again? About 10 years, 15 years?
This is something that we started 2000. Actually, my mentor started way before me, but I joined 2002. And then I left Hungary 2010 and returned to Hungary 2018. The clinic has been ongoing, so I had to just come back and continue.
Okay.
And of course, it's something that you or the patients probably see on the web. I teach for a whole variety of societies, pain procedures, including like all these ultrasound and fluoroscopy guided procedures, including the neck, of course.
Awesome. So with the anterior injections to reach the alar and transverse ligament, how many of those procedures would you say you've done?
Probably in the hundreds, I would say.
And then how many of like posterior cervical injections have you done?
It's something you don't keep track of, but I started doing them 2010, 10, 11. So it's a I don't know, maybe 2, 3 a week. And then you do the math, and I'm sure there's vacation. Several hundreds, 1,000 maybe.
Okay, awesome.
2,000. The one thing that we counted is that we just in the Hungarian clinic, we used over 10,000 PRP and stem cell kits. So that's a big number. That's something that not counted, right? But that doesn't count the prolotherapy procedures and others. So it's a lot.
Awesome. So just kind of starting from the bottom. So for people who are, still trying to figure out, it's kind of like a mystery illness, and I've been through it myself and am going through it currently. One of the difficulties is like just the diagnostics themselves and the diagnostic criteria. It could be really just sneaky. What sort of diagnostics do you typically have patients go through if they come to you and think, hey, maybe I have CCI? Everyone's saying I'm crazy. I don't know what to do. I don't even know what's going on. And you go, okay, go do this. And then we look at what?
So maybe I tell you the evolution of my arrival to this. So all these patients who came to me at UW, coming from the headache clinic and elsewhere, they really did seem crazy at the beginning, right? Because they have this whole variety of symptoms, the headache, the visual fog, the difficulty concentrating, the neck pain, the GI symptoms, and I can go on and on. But when you see 2, 3, 5, and they all say the same, then you start thinking that maybe it cannot be all crazy, right? So I would say, for the most part, I think the clinical history is absolutely key. So if someone never had headaches, never had migraine, and they suddenly have an accident and they develop the migraine, that's not a migraine, right? It's a cervicogenic headache, which could be from the CCI area, right? So the history is absolutely key. The physical exam is the other key. And there is a very specific physical exam. I would say DOs are real masters in that. I learned a lot from osteopaths in the States of how to examine, how to feel for the instability or the block of the C1 and C2. I also learned a lot from chiropractors, actually. the upper cervical chiropractors, Blair practitioners, and NUCA practitioners. So physical exam is the other key. And then, of course, like having imaging is grand because it's so visual. You can do your measurements, right? So the measurements that Centeno always talks about, the Harris 1, the Harris 2, the angle measurement is all, I would say, basic for neurosurgery. Okay, so it's not a magic. It's well established for neurosurgery. These are, I would say, additional information to be more certain of your diagnosis. But honestly, physical exam and history, I would say, is 95% of your diagnostic certainty. And of course, if you see that the millimeters are off and the C1 is slipped off of C2 and all those, yeah, it's even better, because then I can say, look, here are the numbers proving that you have a problem. But you can be pretty sure by this constellation of the symptoms.
Cool. And I think you mentioned maybe on your presentation something about like flexion extension MRIs that you look at as well sometimes.
So here I have one MRI that I organized that I can, if I have a question, I can do flexion extension MRI or rotatory CT or flexion extension CT as well.
Okay.
I do my own DMX here in the clinic.
Oh, you have a DMX on hand?
So if you really break it down, the CMX is a fluoroscopy that is able to record a video. Okay. That's very simple.
Yeah.
So you can do your own DMX and do your own recording and do the measurements. So that's what I do typically. If I have a question, I send them for flexion extension MRI, and some patients actually come with the ready DMX report.
Awesome. Yeah, that's one thing that I like about some of the clinics, is that the doctor who's diagnosing and evaluating you and treating you also obviously should have a hand in the parts upstream, the diagnosis as well. And like, hey, I can't see what's happening, so let's do this, as opposed to just whatever you show up with is kind of what we go off of.
Yeah.
So I think it's smart.
Actually, yeah. I don't know if it helps patient, but I just had a patient like an hour ago. It's very nicely visible on this. If the CRM is still on, which I don't know. That one, the C1 to one is arthrotic, the other is not. One is slipped off the other side, right? So it's nice, and it was corresponding to my palpation, where the C1 I could feel being a bit off to one side. So it's a nice confirmation of my diagnosis.
Sure. Do they have is digital?
A patient that Hungarian that lives in the States and came to me.
Do they have digital motion X-ray like in Europe? I think that's
honestly, I have never seen a report coming from Europe. All of them come from the States. I heard there is one in Copenhagen, but okay. I wasn't able to hunt it down.
Interesting. Yeah, they're like banned in Canada, I think. And most places have no idea what that is.
Are they banned actually?
I think it's yeah, I think it's because they have the private healthcare system or something with that, but I'm pretty sure it's like actually banned, like not allowed.
A lot of things are not allowed. I practiced in Canada. A lot of things are not allowed, but I don't know.
I couldn't tell you. That's just a rumor. But cool. So then on to just kind of the equipment and sort of patient safety stuff, just general things. Could you walk through the equipment that you have in the operating room, specifically that you use for the anterior injections? So obviously it's C-arm fluoroscopy.
You want me to walk around and show you?
Sure. Yeah.
Now that I'm here, I thought. So look, first of all, lovely bronchoscopy, sitting there, yeah?
Okay.
So I have a bronchoscope, I can peek into the mouth if needed, yeah? And here's the procedure room, yeah? Okay. I have an ultrasound because most of the cervical procedures, that's an ultrasound machine, are done ultrasound guided. And for the craniocervical, there's a C-arm. Yeah. And of course, there is anesthesia machine there, because once you give anesthetic, you need to have anesthesia machine, and the rest is really just standard stuff. Yeah. So for safety, such a good question, because it's a high-risk procedure. Everything that's in the neck, I always tell my patients, not only the craniocervical junction, the neck itself is high risk. We have all kinds of exciting structures there, right? Like the cord, the arteries, the nerves. It's super exciting. So you need to have a really good understanding of what's in the spine and need to be owning good needle skills. Okay, I think that's the most important for patient safety. The other I would really recommend considering for patients, if they are getting an anesthetic, if the airway is compromised, possibly compromised, then is there an anesthesiologist who is able to handle airway issues? Okay. So here we have 1 neurosurgeon and 5 anesthesia doctors. That's good. So when I work, I am the surgeon, and I have an anesthesiologist who only attends to the airway. And because patients have different body habitus, some with a thicker neck, bigger neck, shorter neck, their airway doesn't stay patent so easily. So I used to not intubate patients, but then I learned if my standard is to intubate them all, which means for the patient that they get an airway tube only for that 10 minutes while I place my needles, because then it's really nice and safe. And then it's just like a general anesthetic, but a very short one that we do. What else? I think that's key. And then again, placing the needles nice and safely is the next.
Absolutely. Cool. One thing that's been mentioned is back to patient safety is that, especially when doing C0 to C1 posteriorly, there's obviously the vertebral artery, which could be a big risk. So what do you do to ensure that you're not going to hit that one?
So I've been fascinated with this area. My article is actually submitted of a technique where the vertebral artery is not compromised. That's a technique that I came up with back at University of Washington Times, but I never bothered to publish, but now it's submitted. So if you look at, wait a second. If you look at the cervical spine, hold on, I need to fix this guy. There is a specific area where the vertebral artery actually never goes, which is mostly the front and top part of the joint. And that's accessible from the side. That's the technique I developed, again, back at UW. That's the one I've been using. And we did do a retrospective review. There's never a vertebral artery puncture. So that's kind of nice. Okay. I do have DSA as well, and that I use that too. But I also find that with this technique, the artery is never there. So I would say it's pretty safe technique.
Awesome. And DSA being digital subtraction angiography to make sure the dye doesn't go in the...
Yeah, so this is of course a concern. There have been a couple of case reports published, not for the craniocervical junction, more for the lower areas. So if you inject in the vertebral artery here, not just up here, but even down here, the red one, yeah, you can dissect the wall of the artery and can create an infarct in the occipital lobe, and that would be a real problem. So that's why we tend to use DSA to avoid. You can see if the contrast is within the wall of the artery or in the artery. If it's clearly in the artery, then there's blood return. So that's an easy thing to see.
Cool.
Okay.
So on to the kind of like examination day. We've talked a little bit more about this, but you mentioned one of the important things is like that hands-on exam. So just generally in, a minute or so, could you tell us what goes on that day? It's palpitation and maybe some, I don't know, check their arms.
This is also really pretty standard. When you examine a patient, it could be either the neck or the shoulder or the knee, doesn't matter which part. It's we follow a pattern. It's, again, I don't want to over mystify this, but we look at how you hold your head. Do you have a forward going head, or do you have a normal head carriage, right? We look at how you move, active range of motion. Patients with severe neck problems typically would have a decreased range of motion because of the muscles being so tight. After range of motion, we do a palpation, which means we palpate specifically all these joints, all of those, the back of the spine, some nerves that run at the back of the head. You feel for the C1 process, and you identify if there is a so-called blockage of the upper C1 and C2. That would be a typical thing. Neuro exam, of course, is another basic. If patients have numbness, tingling, weakness in the hands, legs, that needs to be found out. And then the imaging, we look at the imaging. Good. That would be a standard approach to this. Simple.
Sure.
I do something, honestly, I teach a lot, and I think I'm a simplifier. It's easy to understand. All of these are no rocket science. You just need to pay attention and then do.
Once you have experience, for sure. For us patients, it's like, what is Atlas? Why is that even important? It's so confusing. So
I know.
Yeah. Cool. So onto some of the cell stuff. So I noticed on your site, I think it said for that interior injection, you sometimes do PRP, sometimes do bone marrow concentrate. Is that right?
Yes.
Okay. So you offer both?
I offer both. And truly, if you look at the literature and you look at the experts, and discuss with the experts, I would say I spend a lot of time even in the States as well as in Europe at conferences. And we always had this discussion, like, what do you do? Like, bone marrow is so much more expensive. Is it really worth it, right? So we used to say, yeah, do bone marrow because it's better. But now there are 2 really big studies that are out. And I'm sorry to say, they didn't prove that bone marrow is that much better. We also have some evidence that none of the stem cells actually stay there. A week later, less than 1% of the stem cells are there. So I always, when I discuss this with patients, I say, look, we can do stem cells. It could be fat-derived. Fat is a bit different. I will discuss that. But bone marrow, aspirate, or PRP, one is a Mercedes, the other is a Toyota. Honestly, a Toyota is a really nice and safe car. So don't take a mortgage to buy BMC, because the PRP might be just as good. Now, the one thing that may be different is the fat-derived stem cells. It's a bit thicker. It has more viable stem cells. And also some studies show that actually that has better outcome. But when I say studies, I want to warn the patients that there are no studies for craniocervical junction. Most of the studies, most of the evidence we have is for knee, for tennis elbow, and some little for lumbar spine, some for hip and other joints. But most of the time, we kind of draw a conclusion from the areas that are most investigated. Okay. Now, it's more and more coming up for spine. So we have now nice randomized controlled trials for lumbar spine, for disc, comparing stem cells, comparing PRP. And this is how we're starting to see that, BMC might not be that much better. But we have almost no data for thoracic spine. We have almost no data for the cervical spine. We have a couple of case series, which in patient language or layman's term, I would say it's very little. So we can say it's in experimental phase. Um, the other reason that the fat-derived may be better, but again, there is not much proof, is because it's a bit thicker. You actually need a bigger needle to inject, and it may stay a bit longer because it has some fat particles, little.
Interesting. Yeah, I was talking with a neurosurgeon who studied at the University of Oxford, and he invented some sort of like hydrogel or some sort of fibrin that mixes with the bone marrow and PRP to, because he said the same thing. It pretty much, it's hard to keep it on that joint, so they're trying to figure out how to keep it stuck to that to keep the cells there for a while. So
But again, this is still experimental, and I do that, for example, for an Achilles tendon tear. I see the crack, or a meniscus tear. I see the crack, the crevasse, and I put the needle in, and I inject this kind of thick fluid in. That makes sense. Okay.
cool. So in the US, we have quite a history with stem cells and politics and sometimes religion and all these things. So we can't, we're pretty limited on what we can use. And with that, it's hard to even know what works because it's not been applied. Um, is Hungary the same? So I guess the question is, are you allowed to culture expand bone marrow concentrate, adipose, or anything, or is it similar?
I would say it's all a bit like a Wild West, and Hungary is even way behind in regulation compared to the States. So I am following the US guidelines because I think that's it doesn't protect me, but it's been thought through, and that's what I decided to follow, maybe because my training is from the States. So I do not culture, I do not manipulate. All I do, take it out, spin it down, put it back. Same day, no storing, no nothing.
Cool.
But again, I really don't see the need. Maybe it would be even better outcome. But what I find, the key to success is actually identifying where the laxity is, where the instability is. So if I identify the spots well, and I put my needle there, and I use a good quality product, that's key. Awesome. I would say finding the right target is more important than what you inject. I actually sometimes say that the poor doctor's PRP is prolotherapy, which you or many patients probably know is actually a sugar solution. That's not something I do for the craniocervical junction, by the way. And the reason is because it's a high-risk injection. I would have to go back many more times with the prolo. And I can't justify the risk of the procedure to save a little bit of money for the patient.
Sure. Yeah, needles stuck in your neck. You want the least amount of that as you possibly can. I know it very well.
Yeah, but I do cervical prolo a lot, but not the craniocervical junction. But like cervical prolo is nice and safe, in good hands with ultrasound guidance.
Cool. Let's see. So when they get bone marrow concentrate, do you give them a total nucleated cell count, a TNCC with that? Oh, okay. For PRP, do you do any platelet counts?
No, I don't. I do check baseline platelets. So everybody comes with a blood draw. And what I did myself, I'm using the M-Site kits. And that's, I think, one of the nicest quality kits. It's a double spin kit. And I know the company's papers about their cell count and their concentration power, but because I like verifying, I actually made my own measurements at some point with the big lab. And once I saw that it multiplies just fine, now I don't check the blood here in the office.
Okay, cool. The last part that I had for you here is just kind of generally how the results have been. I found some threads on the internet people saying anecdotally all good things. Maybe even at like a separate time, if you could throw together some case studies before and after, any sort of evidence that shows this works, or what a patient's saying, or anything on your side.
You want to hear stories about patients? Is that what you like?
Well,
because I have anecdotes, but as a doctor, I can tell that there is no value in anecdotes. I know patients like it, and I have amazing anecdotes. I'm not very good at collecting evidence because I work rather than working on marketing. I don't have the extra team for that, but I have some, yeah, of course.
Yeah, it's a tough spot. We're relying on anecdotes because it's all, like you mentioned, still experimental and not really established. But
So
generally, go ahead.
what I started doing, I actually had a patient who got so well, a lumbar spine patient, and he offered, like, said, what can I do for you to compensate? I've been to so many doctors and now you fixed me. And I said, I just want a little bit of an Excel file for my data collection. And this lovely patient developed a whole platform for me for data collection. So since that, so for 2 years, or maybe, yeah, 2 years, I've been collecting data. It's amazing for me to see that actually what we do works or it doesn't work. So I have some data now on the CCI, but it's nothing like, it's just the last 2 years, right? It's not much. But what I can say that I think almost all patients had really significant pain relief. Some I even show in my lecture, like I think 7 or 8 patients.
I saw that. Yeah. Cool. Last question. So, is there anything that you've maybe new like discoveries or improvements on how to do the anterior injection? Anything else that you've worked on and come up with? Anything else you want to add?
So the whole thing is pretty new, right? We all understand that it's. I understand from you that the anterior approach is only practiced in India and Serbia, Hungary, and in the USA, right? So I hear. I would say what I learned, I did have 3D printed mouthpieces, but then I realized it's much safer to actually intubate the patient, much safer, because there is never a patient that gets sedated and then the saliva would drip down and compromise the breathing. This is just a nice, safe way of doing the procedure. Other than that, it's so much detail. I don't know if it's of interest to patients. I could have a conversation like that with a doctor, but
Cool. Just curious if anything stood out. Yeah, I'm sure that there's a lot more to say here.
I mean, you always perfect your techniques, right? Even the things that you do for like 5 years, and you think, there's a much easier way, right? So, for example, the one thing I think Centeno didn't do when I went to see how he does the procedure, I'm using a curved needle, right? Which means, but this is, I'm not sure it's of interest for patients, but if you have a straight needle, you have to redirect multiple times to get to the right target, fluoroscopy guided. I have a curved needle, which means I can steer my needle to the target. But it's a minor detail, and there is no best way, and there's no comparison if one way is better than the other. I find this is faster, better, easier. But again, it's a minor detail, and the patients, I don't think patients need to worry about it or think of it even or consider it. It's minor technical detail.
Cool.
I can tell you, actually, I can tell you one thing that I learned, and it's useful for patients. Oh, here I think of one. So the beginning, the first few years, I always worked with manual therapists and chiropractors. And the first few years, I sent my patients always to these manual therapists. And here in Hungary, we don't have chiros, we have manual therapists, and we have some DOs. And what I learned over the years is that don't touch a cranial cervical junction patient for 6 weeks after injection. And this is something that I would recommend considering for the patients as well. Because if there is an instability and I inject into these ligaments, I create a temporary injury with the purpose of regeneration, of course. But I find that temporary, these ligaments are actually more vulnerable than even before. So you don't notice the symptoms don't have to get worse. But if a chiropractor or a manual therapist cracks and turns, you might lose the benefit that you gained from the procedure. So go careful on the adjustments and those.
You're thinking around 6 weeks to let those cells kind of inflammation phase stop.
Now I don't let anyone touch the CCI patients at all, or CCJ patients at all for 6 weeks. And then they can go gently.
Sure. Cool. Great. Well, those are all the kind of questions. I mean, I'm sure we could talk for hours and hours here, and maybe we'll do another one and get more info out there. But so the clinic is, and sorry, I've seen PSI pain clinic. I've also seen Fajtalum Clinica.
Yeah,
That's how you say it.
I love your pronunciation. Yeah, it's Fajtalum Clinica. Because psi-clinic.com, it's the same website. It's the English and the Hungarian version. Hungarian patients can never pronounce PSI clinic, and but it's the same. We have an international pain school where we train other doctors, and that's Pain School International, which is another website, of course. And the clinic is linked to that. We do some of the teaching here. So it's psi-clinic.com.
Cool. And I'll put like a link to book a telehealth if they want to chat with you privately about, what's going on and see if it's right for them and stuff. So
what I do have patients coming from abroad. Typically what I do is that they sign up, they send me all their data, including imaging and reports and everything. Then we have a Zoom consultation, and then we discuss which way to go. And when they come for the procedure, I do a physical exam to confirm if we were all both on the right track or not.
Cool. Well, anyways, thanks so much again for taking the time out. And yeah, that's it.
Thank you so much. And everybody should get better. It's not something that should go untreated, really.